Good evening, everyone. Yes. Good evening, everyone. Welcome to this CME today. The CME today is on a good topic that we have discussed about, that we started this week, I think, by Professor Kiage. It was about business, and we are lucky here today that we'll talk more about the business today. So kindly let me introduce Dr. Kiage, Dan Kiage, who is the medical director of KCI Center, will be the moderator. And so Dr. Prof. Kiage, you can take over now. Then after your presentation, I'll introduce the sponsors of the day to give us a small talk, and probably might have an announcement from our president. Welcome, Dr. Kiage.
Thank you, Frank. I hope you can hear me well. So I have the privilege to introduce my friend, Dr. Ernest Ollando, who is a speaker for today. As we all know, Dr. Ollando is formerly an ophthalmologist in Sabatia Eye Hospital. Now he works in MTRH. He also runs iDocs Limited as his side hustle, and I hope he's going to tell us more about it. Dr. Ollando holds a fellowship in pediatric ophthalmology, and he has an MBA in healthcare management. His talk is going to be Business of Eye Health, Exploring the Value Chain. As you are all aware, we will want to participate actively, and we welcome you to ask your questions on the chat, and we'll ask him to tackle them, or anybody else who could, after the discussion. So I don't know if Dr. Ollando should take it away now, or do we have the sponsors talk before that? Usually it comes at the end.
Yes, we love the sponsors at the end.
All right, so in that case, then Ernest, take it away. Ernest, are you there?
Unless you are requested. That's the thing.
Dr. Ollando, can you please unmute?
Mute. And then,
okay.
Yes. Okay, good evening, everyone. My name is Ernest Ollando. I'll take us through the session today. And
Mute this one.
can I share my screen? Okay, can you hear me?
We can hear you well, and we can see your slides.
Very good. So the presentation is about the business of eye health, and we are looking at the angle of integrating into the value chain of eye health.
Ernest, can you kindly make it a slideshow?
Okay, that's fine.
Okay, that's better.
Yes, so the topic is the business of eye health and how we can integrate into the value chain in eye health. So this presentation has been informed by the recent perspectives or concerns of some ophthalmologists regarding our role in the eye health value chain. So we took note of this, and also the several questions asked in the recent past. For example, if I've done a fellowship in cornea or whatever else, then how do I plug into the value chain so that I can offer these services to the best of my ability? There, in the WhatsApp group, there have been attempts to address some emerging issues, and this is noted. However, I felt that there are several gray areas that still exist, especially for the youngsters, the young ophthalmologists who'd like to chart a clear path for themselves. And in some of the questions that have been asked, therein lies the answer in many instances, and I'll explain later on. But the big question is, how do we integrate into the value chain? The eye health value chain can be described as a full complement of activities that are geared towards providing eye health. Simply put, is the systems and processes that we engage in to create and deliver value to our clients in the eye health sector. So we'll be looking at this in terms of the public eye health system and also the private eye health system. And we recognize that in the public eye health system, that's where most of us practice currently. And the rest practice in a private eye health system, which comprises the major eye hospitals, social enterprises, group practices, solo practices, amongst others. And next, I'd like to spend some time looking at a generic value chain. And the main thought leader about the value chain framework is called Michael Porter. He wrote a book in 1985. And in that book, what he tries to describe is the systems and processes that different businesses, in the classical case, is companies. The processes that they engage in to be able to provide value to their clients. And value here refers to the products or services that they provide to their clients. And so he looked at this in terms of primary activities that the traditional industries would engage in. And these would include things like inbound logistics, operations, outbound logistics, marketing and sales, as well as services. And if I may relate this to the business of eye care, inbound logistics, for example, taking the a scenario of spectacle services. Inbound logistics would imply things like sourcing for frames and lenses and whatever else goes into making the spectacles. The operations would be things like refractions and glazing services and so on and so forth. The outbound logistics, given that example, would be the finished product, the spectacles that you then dispatch to your clients. And of course, there's marketing and sales as well as service that goes with that. So those were classified under primary activities. And to facilitate these primary activities, there are support activities such as infrastructure. And in its concept, infrastructure here means the planning for the provision of such services, the financing, keeping tabs on the quality, information system, and so on and so forth. And then there was the human resource management. And most of us at this point in time, especially those who are employed, this is where we interact with the value chain, as we are so highly trained to be able to provide a service to our clients. So that's human resource management. And then there's technology development, and the world of ophthalmology is heavier on technology. We all know what technologies have come about in the recent past. That also goes to support the primary activities that are involved in eye care. And then, of course, procurement. Where do the medicines used in ophthalmology come from? Where do the frames and lenses and equipment and so on and so forth come from? So all these support activities are meant to support the primary activities. And you realize that there's interaction amongst all these elements of the value chain. So for business owners in ophthalmology, for example, the main aim is to make a profit and make a decent margin, okay? And so businesses that do very well in eye care and in other sectors try to manage the various elements of the value chain, the primary activities as well as the support activities, and interlinkages in such a way that they minimize the costs and maximize on the profits. And if I may reflect on uh, my journey through ophthalmology, there are times when I've been just an employee, and the way I've interacted with the value chain at that point in time is being a provider of a human resource. But then I realized when I provide human resource, then what I expect in return is that salary or that wage um, or payment for that service that I have offered. But when you are more curious and you want to explore other aspects of ophthalmology, then you begin to ask yourself, where do these supplies come from? How else can I integrate with this value chain? What else can I explore so that the returns to me as an eye care worker are better at the end of the day? So you begin to think of entrepreneurship in eye health. You begin to think of owning some eye health business or having some stakes in the eye health business so that when the full value chain is explored, at the end of the day, you expect to have some returns in terms of profits or sharing of the surplus in this value chain, as opposed to just expecting your salary at the end of the month or at the end of the financial period. So that's uh, derived from the Porter's generic value chain, and this can apply to many industries. Let's now go to a hospital value chain, and this is derived from a book, Managing Healthcare Business by Professor George Mosley. And the central part here, you can see the suppliers, which are physicians, where most of us fall um, in this aspect of the value chain, and managed care organization, the AARs, the avenues, etc. And then on the extreme end, the customers, and he classifies customers here as the patients, payers like NHIF and other insurance agencies, and employers who send their clients to seek services in a hospital kind of setup. And the primary activities then comprise marketing and promotion, emergency room activities, admitting patients into the facility, conducting tests, diagnostics or otherwise, and all the way through discharge planning and rehabilitation, as well as referral and follow-up. Then you realize to the side, there are many other activities like finance and management, there's governance, there's medical research, legal aspects, and down here we have facilities, security, maintenance, housekeeping, etc., etc. Now, when you look at this value chain, the activities that generate income in this process are mainly concentrated here. All these other activities are supporting activities. And so the eye health workers who are participating in these value chain have to work very hard to generate enough income to support these activities, as well as um, the supporting activities. Okay. And so I look at myself again uh, as a doctor in the eye care industry. And I'm like, how then do I interact with this value chain? If I just interact as an employee, then I fall here under human resource management, which means in the overall consideration of all the aspects of the value chain, the owners of the capital, who are usually the owners of the uh, hospitals or eye health businesses, look at me like one of the factors of production, which must be managed so well, and the costs related to me must be minimized, so that at the end of the day, the profit margin is remains decent. But then again, I could interact with this value chain in such a way that I have stakes in the eye health business, so that in the final analysis of things, I also expect to participate in the profit sharing at the end of the day. So that's, again, a hospital value chain that we can all relate to. So the questions I ask myself are, what financial returns, or maybe all of us should consider asking ourselves these questions. What financial returns did each and every one of us get from various engagements in eye health in the last 2 years? 2020, of course, was tricky because of COVID. What about 2019? What are the major contributors to the returns I got from eye health? For example, if employed, maybe I just got my salary for the 12 or 24 months. And if self-employed, or if I owned eye health business, then you begin to think of various aspects of the returns, the financial returns, like consultation, surgeries, diagnostic procedures, spectacle sales, the teaching activities I engaged in, the research and development, consultancies, profits or dividends. And for those of us who are innovators in eye health, the royalties I got from people using my innovations, amongst others. So apart from the financial returns, um, there's an element of non-financial returns. How else did my engagement in eye health benefit me and my family? Because I spent so much time providing eye health. That includes many things, but what comes to mind is like the recognition, like some of us have gotten in the recent past. So the other question is, uh, what more can we do to get better returns from our engagement in the eye health system? Is there anything that we can do? If I'm an employee in eye health and I want to explore various aspects of the eye health value chain so that I get better returns, are there things that I can do? And the final question is, how do we fit into the various eye health businesses that we work in? Are we just employed? Are we self-employed? Are we eye health entrepreneurs or business owners? Or are we innovators in the eye health space? For those of us who do research, do our research findings translate into industrial products or services that are scalable to provide solutions for eye health challenges? So those are questions I've asked myself time and again in a quest to try and answer some of the questions we've had in the past. Further reflection is, are we happy with the returns that we got as above? And what are the challenges for each and every one of us? And what can we do differently to maximize our financial and non-financial returns on our investment in eye health? And what's my competitive advantage in the value chain as I engage in eye health? Is there something that I do better than my colleagues in eye health so that I can like monetize that to get competitive advantage over the others. How can we utilize or monetize this competitive advantage for better returns? Those are questions that are pertinent to how well we get rewarded for engaging in IL. So next, I'd like to take the angle of iHealth systems building blocks that many of us are familiar with, including human resource for iHealth, equipment and infrastructure, healthcare financing, medicines, innovations and technologies, service delivery, and so on and so forth. So the question I ask myself is, what can we do differently so that we can benefit more from the various aspects of iHealth? And if I look at human resource for health, what I can do differently depends on whether I'm employed or I'm a business owner in iHealth. And I can also relate this to my own journey through iHealth. If I'm employed, do I have an employment contract that favors myself as an employee and the employer? Or does it just favor the employer so that I work so hard doing so many surgeries in a day, seeing so many patients in a year, and yet my returns from this engagement is just marginal? How do I make this better? If I'm a business owner, um, again, the same questions apply, but in addition to that, is there a role for collaboration and partnership with other like-minded ophthalmologists or other players in the industry, or even the competition? How do I work with the competitors so that it's mutually beneficial uh, to myself as a person, to my competitor, or to my business as an iHealth provider, and to uh, related businesses in the industry? Is there a role, or would there be a bigger role for engaging in group practice for ophthalmologists, pulling together our resources and having larger outfits that can then engage with the eye health industry at various levels? Of course, having a stronger voice than if I practice as a solo practitioner. Or is there a role for a hybrid model where each and every one of us has their own private practice, and there's this large center where if I want to do FECO, I can go to if I don't have a FECO in my office, or if I want to have expensive or if I want to have access to expensive pieces of equipment like OCT or a corneal topographer, is there a way we can work so that we invest collectively in some of these high-end equipment so that each and every one of us benefits from the availability of these services? And of course, we transfer those benefits to the patient. So to me, the bottom line is it's okay to invest in the best skills possible as an ophthalmologist. That kind of gives you a bit of a strategic advantage because patients just want to see, they want to get the best services available. And so if you invest in the best skills, you're more likely to offer high quality services to the patients. But if my participation in the eye health industry is just as an employee and I don't have a very good employment contract and I'm limited to just receiving my salary, then of course, even if I invest in the best skills possible, I do a fellowship after the other, my returns in terms of financial returns and otherwise would be limited to what the employer feels is uh, justifiable paying me, and so on and so forth. So it's, in my view, a good idea to invest in the best skills possible, becoming better today than I was yesterday. But an even better idea is thinking of having some stakes in the business of eye health that I engage in, if the kind of employment scenario that I have allows that. And one of the things that are dear to me at this point in time is investing in a better work-life balance. You're happier that way. And if possible, diversifying my portfolio so that these years that I have to work and I'm at the peak of my career, I can convert the active income that I gain from eye care into passive income that can sustain me in my golden years. Again, one of the things that I'm thinking of is it possible to mentor other people to become better than me so that as I retire into other things, there are other people who can do what I have been doing even better. Okay, so those are some questions that I've been thinking of. The next building block is equipment and infrastructure. This is a major thing that facilitates uh, the way we offer services and the way we engage with the eye health value chain. And if we have a strategy of investing in critical pieces of equipment for our use as ophthalmologists who are employed or who own eye health businesses, then we are more likely to benefit from the value chain, because when you have equipment, when you own the equipment, there are several decisions that you are able to make as opposed to if you didn't own any piece of equipment. So still speaking on equipment, the big eye hospitals offer, among other things, high-end equipment to facilitate service delivery. But then I've come to know with time that there are affordable pieces of equipment, like operating microscopes, that are just as good for my use, especially for beginners, that you can invest in to increase your chances of benefiting more from the eye care value chain as we had seen before. And I would like to propose that we become increasingly innovative in making optimum use of equipment, especially the high-end pieces of equipment. If you're in a town where a couple of us are practicing and uh, some of us have high-end equipment that others can't yet afford, then it's possible to share these resources in a way that is beneficial to the patients and also to the practitioners. For example, biometry. If at my center I still don't have enough money to buy biometry and I still want to do cataract surgeries, um, it's okay for me to send my patients to another center nearby to have very high quality um, biometry done so that I can then go ahead and do the cataract surgery with good results, as opposed to sticking to my clients and saying, these are my clients and I have to do everything as myself or as my small eye center. So there are things that we can do, like engaging manufacturers in of equipment um, to get concessionary prices. We can negotiate as a group. And one thing I've learned is they're also eager to sell. So if as a group, we're like, whatever piece of equipment a colleague requires, we can help source for that, or we can facilitate that discussion with the manufacturer, then we'll be at a much better place so that people work with equipment that are beneficial to them and of course to their clients. Healthcare financing, it's important to explore the various financing models for your eye health practice. For startups, there are decisions to be made like, do I start off from my savings, or do I take a loan, or do I get an investor to hold my hand through the nascent stages of the um, eye health venture? In terms of revenue, uh, it's a good idea to be able to plan your revenue. Are you going to offer services to cash paying patients only, or are you going to engage with the insurance industry so that you benefit from agendas such as the UHC and expanded NHIF and so on and so forth? So it's a good idea for purposes of cash flow. It's a good idea to strike a good balance so that the business has some cash to run the day-to-day activities, and as your insurance money begins to trickle in, um, you can expand the business. So in terms of medicines and technologies, how we can integrate into the value chain is by sourcing for and supplying quality medicines to uh, our patients. For example, at some point in time, I was these ophthalmologists who sees a lot of patients and generates a lot of prescriptions, which then went out there to various pharmacies and they changed my prescriptions at will and they changed the medicines I prescribed to the patients and they changed the dosage schedule and so on and so forth. So at some point in time, some patients would come back and they're not getting better and you looked at the medicines they were given instead of having a 2-hourly steroid antibiotic drop post surgery, they were given medicine written 1 times 2, something like that. So I was like, instead of patients going around all over town looking for medicine and having such challenges, why don't you invest in that aspect of the business so that um, you can, for one, reduce the cost of the medicine to the patient, and number two, provide everything under one roof. In terms of innovations, it's okay to collaborate with the industry, and some of our senior colleagues have done this. Uh, Innovations such as Speak, is it possible to bring that innovation to scale, working with the industry? And while at it, always remember to protect your intellectual property rights. It's also okay to embrace newer technologies in the process of diagnosis and treatment. Of late, people have been talking about uh, fecal emulsification surgery as opposed to just doing small incision surgery. Of course, you weigh the benefits versus the investment. It's also okay to find local solutions to eye health challenges where possible and to collaborate with other professionals so that we can um, um, continue to provide value to our clients. So service delivery, the overall aim should be to provide quality, comprehensive services that is safe, timely, efficient, effective, equitable, and patient-centered. I'm almost coming to the end of this. For eye health information systems, however small my eye health venture is, now more than ever before, I know that it's useful to collect information about the various activities the business engages in and to review this data about the various aspects of the eye health enterprise and to use this data for continuous quality improvement. Part of the plan is to minimize wastage so that at the end of the day, if you remember the diagram on value chain, if we minimize wastage, then the profits or the financial returns on the investment are much, much better. Regarding eye health leadership and governance, it's okay to invest some time in becoming a better eye health leader. All of us are, by virtue of our training, by virtue of our positions at the workplaces. And it's okay to collaborate with other key players in the process if you can. And I'm always reminded that strategic partnerships are beneficial to businesses that seek to have competitive advantage over the others. So network with the industry, with other colleagues, with other cadres, and so on and so forth, so that you can benefit from the strategic advantages that you have gained by virtue of your training and your position in the eye care value chain. So what do we understand? What do we stand to gain by integrating into the value chain? Again, by integrating into the value chain, I mean, if I was an employee in the eye health space, then now I own an eye health business. There are things I can do as an investor in eye health now uh, that I couldn't do as an employee in eye health. And traditionally, this applied to companies. For example, a manufacturing firm or a retailing firm integrating upwards into the value chain so that they buy off a manufacturing firm so that they can have a continuous supply of the things that they sell. And vice versa, manufacturing firms could develop retail outlets so that they could sell directly to their clients and make higher returns in the process. So what do we stand to gain by integrating into the eye health value chain? If you invest in the eye health business, it will allow you to invest in highly specialized assets, like most pieces of equipment in ophthalmology that you can then use to improve your returns on your many years of trading in eye health. You can give it gives you more control over your business, because as opposed to just being
Next time, Emma. Next time.
because as opposed to being just an employee in eye health and being considered as one of the factors of production in eye health, you then now have more control over how much profit you want to make and how you're going to manage the eye care products such as medicine, so that you can transfer the cost savings to your patients. It allows for positive differentiation. For example, I'm a pediatric ophthalmologist. My inclination in my practice is to see as many children with eye diseases as possible. Other people who are vitreoretinal surgeons might want to just focus on vitreoretinal surgeries and so on and so forth. So it allows you to differentiate positively so that you can give your clientele your best. And also there are cost savings to be gained by integrating into the value chain, because when you integrate, you get rid of some of the middle men in the business. I know this by now because I have had a chance to import some equipment directly, and the cost savings were just amazing. It ensures higher levels of certainty when it comes to quality. For example, if you're offering just small incision cataract surgery and you're keeping tabs on the quality and also the information management, then for every patient, you'll be able to know what were the outcomes of the surgery, what were the refractive errors, post-op, etc. And this information helps you to keep improving. So in many ways, integrating into the value chain provides more competitive advantage. As with other things, there are always pitfalls when you're trying out new ideas. When I'm venturing into an eye health business, and by training, I've just been trained to be able to be an employee and provide services, then some of the pitfalls may be difficulties with capacity balancing. For example, how do I balance my leadership and management roles in the eye care business with being a surgeon and being a lead clinician in the business? It can also create some barriers to entry to the market. Some of the industry players or middlemen that you get rid of in your quest to explore the value chain can really fight back. So there can be a backlash when you try to integrate into the value chain, because essentially you're offering new competition to businesses that have been in that space before. It can also cause confusion within the business, especially if the roles of the ophthalmologist and the other eye health workers are not very well clarified. And last but not least, the capital expenditure can be quite huge in some instances, depending on what angle of integration you take. So in conclusion, the overall effect of integrating into the eye health value chain should be enhanced returns on your investment in ophthalmology. As an ophthalmologist, you stand to gain more if you have stakes in the eye health business that you're working for. As an employee with a better contract that rewards you for the work you do, maybe getting a bonus at the end of the financial period, or maybe being allowed to get shares in the eye health business, and so on and so forth. So the aim here, and for business owners, of course, when you explore the value chain, more and more, you stand to have a more decent profit margin, as opposed to if you just concentrate on the service delivery aspect. So the aim is to have ophthalmologists who are happier with a better work-life balance. And the dream is to have all of us benefit from the many years of training in eye health, even as we provide the much needed care, sometimes under difficult circumstances. So thank you very much. I'll stop the presentation there and we can take questions. Thank you.
Thank you very much, Ernest, for taking us through that. I like the way you've used the building blocks of healthcare management to relate to healthcare. And I guess it's a MBA kind of stuff, which I'm sure some of the younger colleagues need this information to know how to start. I know there are some senior colleagues here who have practical knowledge, who have been there, done that. I do not see any question on the chat, but I think I could wish to open the floor for some additions. I know there are some people here who have had some experiences. I see people from Igor, from CTI. Maybe let's start from Igor, Dr. Kimani, Professor Ilako. Could you maybe make a comment or two about how your journey has been to where you are, maybe some 2-3 minutes, and Amos, if you are there, maybe you can come in for 2-3 minutes to just give you a practical idea how your journey has been in relation to this.
Sorry, I'm on the road. Please allow Dr. Kimani, please take over and just. Kaki.
Yes.
Just comment, please, because I'm on the road and the internet is really up and down.
Okay. All right. Good evening. Thank you, Dr. Ollando, for that good presentation. It had a lot of good points and pointers. But as I had commented, I was looking forward to a more practical interaction. And I guess thank you, Professor Kiege, for opening the floor. I think this is where now we can have the practical interaction. At least Professor Ilako and I have had the challenges and of running a private eye business, and running an eye business is really it's not your usual kind of business, and so sometimes some of the factors that apply to businesses may not always apply. Many times the challenges are because what you invest into the business takes you a very long time before you can recoup. In fact, looking back, I imagine if the money we have put into our business, if we had even just put it into treasury bonds, maybe we would have made more money from that. And the problem is you buy expensive equipment and you hope that maybe it's not just you using it on your patients, that you get referrals from colleagues, but it doesn't always work out that way. I think in ophthalmology, people find it much easier to buy their own equipment than to share. So you'll find you have a phaco machine, your colleague will also set up their own phaco machine, another one will set up their own phaco machine, and then you'll end up maybe doing like maybe 10, 15 patients a month each, when you could be doing the 60 patients a month on one phaco machine. So that becomes a big challenge. And I don't know why it seems, probably, I don't know whether it is peculiar to ophthalmology that people just prefer to invest in equipment in their own private clinics. So you find, like, initially when we conceived about a center of excellence for ophthalmology, we were thinking we could come together as ophthalmologists and put up a state-of-the-art theater, put up a state-of-the-art diagnostic center. And you find that you try that, but it's very difficult to convince people to come together into that kind of a venture. So you end up going it alone. I agree with Dr. Ollando, especially about mentoring the younger colleagues and hoping that you can work together and probably make use of the equipment that you have invested in as a bigger pool of doctors. And maybe that way you might break even. But ophthalmology, it's a very tough business. And also considering you're competing a lot with faith-based organizations and charity-based hospitals who are competing for the same niche as you, also offering maybe the same services, but having a bigger volume of patients. And so that also becomes a bit difficult to compete with them, knowing that probably they also get extra donations, which you as a private ophthalmologist, you may not have access to. Then there is also the issue of the insurance world, where there is a lot of murky business going on, having to give kickbacks to be put on their panels, to even to be paid what they owe you. So it is really a tough business, and I wish, I don't know, I really don't know how we can all come together and make it an easier business and a more profitable business. Because, like, if you look at the West, ophthalmology is one of the best paying careers in the West. But when you look at Kenya, I don't know. I don't know whether it would even appear in the top 6 or top 10 paying careers. Thank you.
Thank you, Dr. Kimani.
Thank you, Dr. Kaaki. I don't seem to see Dr. Kibata here, but Dr. Shafiq Javaji, you've recently started very successful practice in Nairobi. Could you weigh in on some of your take-home practical messages from this talk? Dr. Chafachi, are you there? Chafachi seems not to be there. So I open the floor if anyone wishes to make some more comments, some practical comments of the experiences they have in this field.
Yeah, thank you, Dr. Kiage. I would like to make one comment. Can you hear?
Yes, we can hear you, Hilary.
Yes. So I'll address myself basically towards research and innovations in eye care. And as Dr. Ollando has rightly said, there are quite some challenges, especially in the innovative world, and especially with ideas and the ideation on particular issues. The basic reason is that I think in our continent, and basically in the Southern Hemisphere, the laws on intellectual properties are quite weak. And two, we don't know basically what intellectual property is all about. And by the time you talk about anything or you come up with something, the other people will have already, they'll just discuss with you and already have that idea and register it elsewhere. So that, I think, is quite a challenge, and especially for the young ophthalmologists who are coming up and maybe have ideas. I think right now it might be good to start discussing with the KIPI. KIPI is actually an institution whereby you can, it's called Kenya Institute of Intellectual Properties something. KIPI, you are able to register your ideas and they are kept for some time as you develop them. With that, then you are able to keep them yourself. But also universities, I think, as you are also incubating knowledge, there has to be a way of linking up with KIPI as well, so that such ideas that come up with from the students and from the student body, the university are able to progress that and turn into market leader ideations. So there's still some room, especially in the technology side and also on the innovation side of eye care.
Thank you, Hilary. Shafiq, I think you're back. Can you maybe make some few comments before we look at some of these questions here?
Good evening, everyone. Thank you, Prof, for giving me the opportunity to speak. And I must, first of all, congratulate Ernest. That's a difficult talk to do, especially for an ophthalmologist and more so for an eye surgeon. Just a few things. First of all, I think having somebody senior with you whenever you're trying to get into anything, even if it's business, is important. As a young ophthalmologist, when we're trying to get in, we have lots of doubts, we have lots of fears. And having a senior person with us helps to allay a lot of that and give you a lot of confidence towards doing any business, getting into any business entity or any entrepreneurship. Having said that, when setting up any business entity like what we have, one of the key successes I feel was we invested in property. Because today in Nairobi, or maybe even anywhere else in Kenya, rents are high, your earnings on rents. So try and invest in property and then run your business. You are earning from that rent in lieu actually. So that becomes one big important issue that you need to sort out. You start off, just make sure that you are going towards a point where you are investing into a property and you have your own property on which you are putting your business. Other than the ophthalmological business, we also run other businesses, and all our businesses are on our own properties. We do not participate in renting out and putting up our businesses. We feel that we lose out on that. Again, it gives you a lot of confidence towards doing things with your business. Yeah, you want to make more investments, you want to expand, you're at liberty to do all of that. Next thing is, as I said, okay, the biggest cost is rent. You got to take a plunge. And then whenever you're in a business, you're starting a business, don't put all your eggs in one basket. Now, what do I mean by that? You argue that I'm already putting all my eggs into ophthalmology, but ophthalmology itself is a basket with many eggs. Ollando already had mentioned the spectacles. So you can do the optometry part of it, sell your own medicines, set up your own, what do you call it? Autoclaving, what would you say? Sterilization process, a service which you can offer to the people around you. Like where we are based, there are a number of doctors and all of them need sterilization facilities because they don't even have an autoclave or an ETO, and we sterilize for them, which actually pays off some of our salaries out of it. Yeah. We've got diagnostic. You put up your diagnostics, let the people around you know that you've got this a topograph or you've got an OCT, and a little bit, it will not be much. Everything will generate small amounts, which will help you bring back your cost. Another thing is you're investing into machines. I come from a community where we do not partake interest. So even as we take loans or anything, we avoid taking interest. And a huge chunk of your earnings goes away towards paying interest. So try and pool, as again, Ernest had said, make a group practice where you come and put your money together. And one of your first earnings will be that you're not paying any interest to anybody. You are eating your own interest. Yeah. And that is how you're able to lower your costs and improve your services. And well, yeah. I think other than that, every business has a goodwill to it. Yeah. That's the non-financial part which Dr. Ollando was talking about. And goodwill has to be built in all different ways. Sometimes you just got to give a patient a pair of glasses for free, or you allow a colleague to do something, comes in, you know, they're in a lurch, let them do something there. It's okay. Yeah, it is not always about the money. When you have a facility that you are running, it's not always about the money. Build the goodwill. That will bring back the financial returns also. So these are some of the few pointers which over a period of now, I think we have been in it for about 3.5, 4 years. These are some of the few things that we have learned. Of course, there are many other aspects, patient related, your staff related, there are many other aspects. They're just a given few. Thank you.
Thank you.
Thank you, Shafiq. I think we're just about to run out of time. I guess, Dr. Owen, maybe your question has been answered by what Shafiq has said and what Kimani said. Maybe I can just take a minute to respond to Dr. Nyense. He wanted me to comment on community practice. I guess he's basically talking about the rural kind of practice that we did. I think maybe we need a day for that, but just the basic foundation for that thought was that the quality, the high quality of eye care that is given in Nairobi is also required out there. And to be out there in the community, there is no way you can practice the same way we can practice in the city, because the rural community here has got like about 56% of the people who are poor, but they are needy. So that's where the social enterprise model comes in, where you can see the people who don't have money for free or for very little, and also ensure that you are giving people who have a bill to pay or who have insurance the very high quality eye care, so that you can make the money. So the thing is that there is still need for looking at our brothers and sisters out in the community who cannot fend for themselves, who do not have the money. When you find somebody who doesn't have 500 shillings to pay for NHIF and who doesn't have enough money to afford even like 10,000 shillings to afford a small incision cataract surgery, then these people also need our help. But fortunately, you can have a mix of this and be able to help these people, but still be able to make the money. So the social enterprise model that we piloted in Kisii has proved to be successful, because one thing, you get to do a lot of cases so that you can also help to improve your skills and offer opportunities for learning for junior colleagues and the students doing electives. But you also are able to offer the top-notch practice that is offered everywhere in the rural community. People have never probably heard of the word FECO or anything like that. So I think there are challenges and successes in that. And I hope given chance, we can have opportunities to discuss some of these in details so that, you know, people might wish to try them out. So I guess we could, I don't know if there's any burning questions, or I can turn over to Frank to run the rest of the session, and so that the sponsors can also have a chance to speak. Frank.
Okay, thank you, Prof. Kiage. Thank you, Dr. Ollando, for the nice presentation. Thank you for exciting our minds and giving us a clue on the business. Thank you, Professor Kiage. Professor Kiage, I didn't introduce you well. He's a medical director and a glaucoma specialist. He's a medical director in KCI Center and a glaucoma specialist. He has also worked in Nairobi, and he came to offer services in the rural community here, running the social enterprise. So I hope Prof. Kiage have done justice to the introduction. I also forgot to introduce myself. I'm Frank Okada Nyakawa. I work in Nyamira as an ophthalmologist. Now I'd like to introduce our sponsors today. We have John Oriwa. John Allagan, we know him famously as John Allagan. Let him present briefly. We give him a minute or so to present, then I'll close the meeting. Thank you very much. John Allagan, welcome. John Allagan.
Can we stop the other presentation for me to share?
Yes. Oh, yes. Dr. Ollando, you can please stop the presentation. Okay, John, you can go ahead.
Okay. Can you see my presentation?
Not yet, not yet. It's just showing that you have started screen sharing.
Okay. Can you see it now?
Not yet, John.
I don't know why it was. Let me try to share it again. Let me stop and share again. Okay. I don't know what is pausing it.
Supposed to pay for our yearly subscription to our society so as to continue receiving
Evans, maybe we can do the way we decided then. Can you share the one that I shared with you so that we don't waste more time?
You could click onto the one I'm seeing on the screen, click onto the dry eye disease management, or stop sharing so that I can share.
Let me stop sharing. Okay. So move it a bit. So can you go to the start? Okay, thank you everyone. Good evening to all. I want to thank Frank for giving me the opportunity to discuss with you about our portfolio on dry eye disease. I also want to thank Dr. Ollando for a very good presentation, exploring the value chain. And I also want to thank Professor Kiage for the good moderation for today's topic. So I thank also OSK for giving us this opportunity. As I've been mentioned before, my name is John Oriel, and I work for Allergan as a territory manager in Kenya. So the next slide. So I'll start by just defining briefly what dry eye disease is. So dry eye disease is a multifactorial disease of the ocular surface. It's characterized by loss of homeostasis of the tear film and is accompanied by ocular symptoms in which tear film instability and hyposmolarity, ocular surface inflammation and damage, and the neurosensory abnormalities play etiological roles. Next. So there are two types of dry eye disease. The evaporative dry eye disease, that's the lipid deficient. And also we have the aqueous deficient dry eye disease. In terms of symptoms, what differentiates the two is that in the evaporative dry eye disease, most of the patients wake up in the morning already feeling discomfort, and they have excessive tearing, burning, and stinging sensation. But in the aqueous deficient dry eye disease, the main symptoms is usually dryness and foreign body sensation. And most of the times, this worsens as the day progresses. So they wake up okay, but as the day progresses, they start feeling these symptoms of dry eye disease. The most important thing at the end of the day is to try and tailor our management of dry eye disease based on the specific type of dry eye disease. And glad to tell you from Allergan, we have our artificial tears that can be used to help in management of both the aqueous deficient and the lipid deficient. You can move to the next slide. So most of the dry eye disease is usually in a vicious cycle. So most of your patients will be stuck in this vicious cycle, and they will need your expert help in breaking the vicious cycle of dry eye disease. So it starts usually with the tear film instability, then tear hyposmolarity, apoptosis, and eventually inflammation, which destroys the goblet cells, and the cycle continues. Next. So we all know what causes dry eye disease. Majorly is recovery from surgery, environmental conditions, and contact lens wear. There's also meibomian gland dysfunction, certain medications, and of course, hormonal changes in menopausal women. Next. So common symptoms of dry eye disease includes grittiness and foreign body sensation, burning sensation, stinging and itching, and watery eyes. Let's continue. So from Allergan, we have all the products that you can use in management of different types of dry eye disease. So let's look at the product portfolio that we have from Allergan. Next. So recently, just 2 years back, we launched the new Optive family members, that is Optive Fusion and Optive Gel. And they're all anchored on the power of 3. So I'll be discussing all the portfolios that we have next. So the power of 3 in Optiv fusion, you can see it's a combination of hyaluronic acid, carboxyl methylcellulose, and the osmoprotectant salts. Allow me just to mention here that the osmoprotectant salts are the glycerin, L-carnitine, and the erythritol, which help in recreating the osmotic balance. So the power of 3, as we look at it, we have the hyaluronic acid acting as a fixer in helping in soothing the symptoms. And then we have the CMC acting as the anchor to help in stabilizing the tear film. And then we have the osmoprotectant salts acting as a carer to help in protecting the surface of the eye. Let's continue. So just to emphasize more on Optiv fusion, the way it works. So we have the osmoprotectants, which are the carers. They help in protecting the surface of the eye. And they do this by rebalancing the tear composition, improving the tear film quality, and also by reducing and preventing the corneal staining. They also help in restoration of the cell volume, decrease through water loss, and also they protect the ocular cells against inflammation and hyperosmotic stress. Let's continue. Then we have the CMC, which is the anchor. It helps in stabilizing the tear film and significantly improves the ocular surface integrity compared to hyaluronic acid after 30 days. Let's continue. Lastly, we have the fixer, which is the hyaluronic acid. And the hyaluronic acid helps in soothing the symptoms of dry eye disease. It works more effectively in combination with CMC compared to treatments which contain CMC alone. Let's continue. So in conclusion, Optiv fusion delivers a rapid, long-lasting relief from the common symptoms of dry eye disease. And you can see from baseline, there'll be a reduction in the symptoms of dry eye. That's the dryness, the gritty feeling, the burning sensation, and aches and pains, eye aches and pains. Let's continue. Then we have the Optiv Plus, again anchored on the, sorry, just go back a little. Back, I think you went far much ahead. Oh, you've gone, I think you should go back a little. Oh. We're in the Optiv Plus. Just go ahead. Yeah, there, just stop there. Just stop, please. Okay, so we're in the Optiv Plus. Optiv Plus, as you can see, it has the lipid component, the carboxyl methylcellulose, and the osmoprotectant salts. So the fixer here is the castor oil, which helps in soothing the symptoms. Then we have the CMC, which helps in stabilizing the tear film. And then we have the osmoprotectant salts, which helps in protecting the ocular surface. Let's continue. So there was a study that was done by Ketcher et al. Of 2014, and the study it's known as the ProLipid study. It was just trying to emphasize on the need to actually manage your patient with the right product. So in this study, they recruited patients who are either having aqueous deficient dry disease or have mixed form of aqueous and lipid dry disease, or purely they're having lipid deficient dry disease. And each of these patients were either on a previous therapy, artificial tear, or they were naive to treatment. So what happened is that the aqueous deficient dry patients only had an improvement of 16% of their symptoms, as compared to the lipid deficient dry patients who had 40% improvement of their symptoms after being put on Optiv Plus for 1 month. So the ProLipid study showed that lipid deficient patients compared to aqueous deficient patients had greater symptom improvement with Optiv Plus, a lipid-based product. Let's continue. So lastly, we have the Optive gel still anchored on the power of 3. And as we've always mentioned, it has a double strength of the CMC. Now it's not 0.5%, 0. That is CMC, it's 1% CMC, but it's also anchored on the power of 3. Let's continue. So I think you can see Optive gel drops is for nighttime treatment. It's a more viscous drop, as you can see. And I've just mentioned that the carboxyl metal cellulose in it is double the strength. Let's continue. So whatever your dry patient needs, Optive has the answer. So for your aqueous deficient dry disease patients, you can always give them Optive fusion during the day and maximize with the gel during the night. Sorry, the recommended dosage is up to 4 to 6 times per day. That is by Dry Eye Workshop of 2017. And it's compatible with contact lenses. Let's continue. For your evaporative dry patients, we have the Optive Plus. As even we've seen in the prolipid study, it will give your patient the maximum benefit. And you can always give again Optive Plus during the day and maximize with the gel during the night, especially if it's moderate to severe type of the dryness. And the dosage recommended by DUCE 2017 is also 4 to 6 times per day. You can give up to 4 to 6 times per day. Yes. And this one is not compatible with contact lenses because of the castor oil. Let's continue, but the gel is compatible with contact lenses. Let's continue. So in conclusion, these are the focus products in management of dry disease from the Allergan portfolio. As I mentioned before, there are 2 categories of dry eye disease. There's the aqueous deficient dry eye disease, and there's also the evaporative or lipid deficient dry eye disease. Whatever is your patient's needs for dry disease, we have a one-stop shop. And that is Optive Fusion for your aqueous deficient, Optive Plus for your lipid deficient, and Optive Gel for the solution for the night. Let's continue. Thank you.
Thank you, John. Thank you, John Allergan, for your presentation. I want to thank you again for sponsoring this CME for today. Thank you, Dr. Ernest Ollando, for your wonderful presentation. Thank you, Dr. Kiage, for accepting to moderate this presentation. I want to just say that we remember to pay your subscription to OSK. Number 2, let us, we'll have a CME on 22nd of this month by Dr. Njuguna and Dr. Jambi as the moderator. So we'll share the topic and the flyer soon. I really want to thank you again for participating. Thank you for the CME committee and the OSK as a general. Thank you very much. I want to wish you a wonderful evening, good night. And now you can leave at your pleasure. Thank you very much.
Thank you, and bye. Thank you, Frank.
Thank you, Prof.